Welcome everyone to our webinar today. We are super excited to have you here, especially on a Friday right before a long weekend. So I'm glad you're taking the time to do this last minute webinar that we put together for you. I think Paul's going to be giving us some really good information about what we need to do to get our offices back up and running and doing what we absolutely love doing, which is dentistry on our patients. So with that being said, everyone's coming on right now, and I just want to wait a little bit longer just to make sure that I get everyone on so that we go over the CE guidelines, because you will be receiving CE credits for this webinar today. So again, thank you very much for joining us. And as we go through the webinar, we're going to be asking you to answer some questions. So please make sure that you plan to participate with that, because we really want to make sure that we can answer all your questions today. If we don't answer it live, we'll answer it later in an email. So what I'd like to do is start off by going over the CE guidelines. Number one, please make sure that you registered in your legal name. If you're having to turn this in for your license, it's very important. I know that when I do my license renewal, I have to make sure any CEs are in my actual name and not my nickname. So if you registered in your nickname, don't worry. We'll give you the email later on where you can send it, and we'll be happy to change that for you. It's also very important that everyone logs in on their own computer. With the webinars and being able to give you CEs, we actually at Benco can have a timestamp to know exactly when you came on and when you leave, so that we ask you please not to leave early. If you do, you will not be able to receive the CEs. If you're watching and you're using your cell phone, it's perfectly fine if you've clicked onto the link. However, if you've used the number to dial in, we don't see that. We don't always see is your telephone number. So we're going to ask that you please provide us with your name, the course that you took with Benco, and your telephone number, and we'll be happy to cross-reference those to make sure that we get you the CEs that you need. So again, where you're going to send those emails to is very simple. It's practicecoaching@benco.com. Again, that's practicecoaching@benco.com. So if you need to send me an update on your name, or if you're watching from your cell phone, send me a really quick email and we'll make sure that we take care of you and that you get the CEs that you came on for today also. And then with that being said, if you scroll down to the bottom, you're going to see a section that's called Q&A. We would like for everyone to put your questions in the Q&A and not the chat. So stay away from the chat. We're going to be actually looking at the Q&A. And at the end, anyone that's asked a question, every single person, Paul's going to make sure that we answer all the questions, even if we don't answer it live. And every single person that came in today will get a copy of that. So super excited to get started. And with all that being said, I get to do my favorite thing, and that's introducing my amazing boss, Chuck Cohen, who is absolutely stepped up as an amazing leader, as he always does, helping us get through all of this hard times that we've gone through. And I know he's super excited about everybody getting back to work. You can see it on his face. It's kind of nice. We're all happy about that. So with that being said, I would love to introduce Chuck Cohen, Managing Director of Benco Dental.
Thank you, Kay. I hope I only live up to the introduction. I'm not sure that I do, but I appreciate the words. On behalf of Benco Dental, we couldn't be more excited about today's program. Getting back to dentistry will require us all to be better at airborne pathogens and the equipment and filters and all the various things that go along with them, as well as COVID-19 testing. So over the past few weeks, Paul Jackson, who's formerly our Chief Marketing Officer and now our Principal Researcher, has taken on the task of being the expert within our organization on these two important topics. We think you'll find him to be very well versed and easy to explain. The cool thing about Paul is he has dental in his veins. He started as a service tech years ago, then was a sales rep, then was a marketing expert, and so he really understands how to take very difficult medically oriented concepts and products and apply them to dental. So in a minute, I'm going to turn things over to Paul, and we think you'll be very impressed. But before we do that, I do want to read our disclaimer. The information and recommendations contained in this report and this program represent Benco Dental's best thinking as of today. However, in a fast-changing environment, we urge practitioners to check with other professional advisors as they restart their practices. And in fact, yesterday, the CDC released their interim guidelines for dentistry. We expect those to change over the next few weeks. So Today's program represents our best thinking as of today, and we encourage everyone to make sure that they are staying up to date with the latest products and news. And with that, Paul Jackson, thank you for being here today, and thank you for walking us through these two very important topics.
Thank you, Chuck, and thank you everyone for being on. And so, as Chuck already mentioned, the CDC last night actually published the guidelines, and so that's pretty exciting, and it's really helpful because there was a lot of things that we had questions about, and this is helping us with guidance. And on this first slide, there's actually the address, because it's a little bit hard to find sometimes. If you wouldn't mind, copy that down and go there and print it out and have something to read this Memorial Day weekend. But I think it'll give you some real insight in how you're going to be able to understand what are the best ways to open your practice. You know, with that said, Chuck gave me a nice introduction about expert. You know, I think all of us are in a time where there's a lot of questions, and you'll see this even in the slides that I will present today. But specifically, we need to be good learners because everything is changing. You know, again, just even last night to get these, you know, CDC guidelines, I tried to put some information in the slides based on that, but I'm sure things will change, especially as we understand this virus and we see how this virus is going to impact our population and our patients. And so it's really, really important to be a great learner and to devote the resources to that. And one of the things, you know, Chuck says that dentistry is in my veins, and it absolutely is. I love dentists and dentistry and what they do for patients. But one of the reasons is because, you know, dentistry is really evidence-based. And so it's a practical degree, it's a practical profession. And so, you know, what we need to do, especially in this time, because some of the things are pretty scary. And, you know, so is to try to not move over to the emotional side, but try to move back to the evidence-based. And so as we go through this, we'll, and I'm sorry for that little intro. I'm not trying to be condescending, but really try to encourage us all to really, you know, stay focused and to keep learning. So CDC. You know, I think a lot of us complain about the government and you know, what's happening or not happening, and I think really we should really appreciate our CDC specifically because, you know, they did come out with this guidance. It's pretty detailed. I think I was very encouraged by it, but they didn't not only came out with guidelines for dentistry and dental care providers, but they just came out this week also with guidance for colleges and last week for camps. And so that's really a lot of work, a lot of research, and a lot of writing. You know, so it's hats off, I think, to our government and the regulators that sometimes we pick on. And then the other thing is that the CDC guidelines, you know, I think they are guidelines, and surely it will help us with the practice of dentistry and treating patients. But also, too, we have, you know, the ADA and our state regulators. And so, you know, please look for guidance there because that's, you know, also impacts, you know, how we practice. And let's see. Oh, yeah, and just one other thing. So, you know, what did I see in the CDC guidelines? You know, so I was a little bit worried, and I don't know how many of you heard about what was started in Canada, but 5 provinces came up with some pretty difficult regulations. And I have a friend that's a Canadian dentist, and he was talking about them, but, you know, they were talking that each practice needs a negative pressure room. They need to spend 3 hours between patients in turning those rooms over. And so, and any extra oral suction would need to be exhausted outside. And so, you know, I really, the CDC didn't have any of those recommendations. They did speak a little bit about a negative pressure room, but, you know, they don't have a 3-hour turnover. Actually, they're recommending that you let the room rest for 15 minutes and then begin, you know, disinfecting the room. So that's a pretty reasonable request to let the aerosols fall out of the air. And then they didn't demand closed operatories. And nothing about fogging, which I think is good. The only thing that was in there that was maybe a little bit of restriction would be that I think they were talking about no Cavitron, and then the PPE for each patient. So COVID-19. So I think this is pretty obvious. It's virulent. The biggest problem with COVID-19 and how it's different is people are actually infectious before they know they're infected, and it's really it's unusual for a virus, and it wasn't even the case with SARS-1, and so it really makes it very hard, to control this virus. Mortality rate worldwide 0.66. We know it's mostly affecting older people and those in nursing homes. One caution for anybody that's a little bit older or not in best health, it does seem to impact people with hypertension and heart disease. That's why it seems to be impacting men and those in minorities maybe at a higher degree. And you keep hearing flattening the curve, but it's not eliminating the virus. And so that's to keep the health system and the hospitals from being overwhelmed, but every life is precious. And so you hear a lot that we need more testing, we need more testing. So we're gonna explore that. So if you could, have a little bit of fun, this is the holiday weekend, so let's use our imagination a little bit. So if you could, think about it, make believe that you're either Dr. BRIX or Dr. Fauci. And so we're gonna go through this testing, but imagine that you're responsible for the testing and recommendations for the whole United States, so over 300 million people. And so now you're Dr. BRIX, and so what are you going to decide? Because they keep coming to you and they say, we need more testing. We need more testing. And so just a little bit of a definition of we need more testing is that there's, as I mentioned, over 300 million Americans. We've tested a little bit less than, but around 10 million already. And they can do about 300,000 tests a day. So if you just do the math on that, that's going to take us about 900 plus days to do the testing. So we need more testing. And so one of the things that's a problem, and it's a problem, Dr. BRIX, we don't know how COVID-19 is spread. And so if I had any criticism of the WHO, and this is not a political discussion, is we've had a long time to try to figure out, how is COVID-19 spread? Because if you don't know how it's spread, then you don't know what are the actions that you need to do to prevent it. And so, so we do know, and this just, again, is in the CDC guidelines, and they talk about that we know it's droplet, but they don't know past that. They don't know, there is strong evidence that it's aerosol, and we all, pretty strongly suggest that, or understand that. But it goes back to when and how long is a person infectious? And so there was a Wall Street Journal article that was in May 21st, and it really gives some clues. And so this is a picture of New Orleans. And so they talked about different super spreader events. And so from the super spreader events, you can get an idea. And so, and it turns out that people together, large volumes of them together, but where they're breathing, and they're breathing harder. So length of time and how much they're breathing and how hard they're breathing seems to be, a factor in how the virus is spread. And so specifically, there were 2 churches where there were choirs. The most recent one was in Seoul, Korea, and there was a lot of spread and in bars. And so, but that's because, the music is loud, and so people have to yell, and they're together for a long time. And so there's some clues, but how that relates to you, Dr. BRIX, is you're trying to help dentists. Well, they're near a patient's mouth for a long time. And so that could be a factor that you might want to take. And so this is a chart, and it's it's not, 100% scientific, because we don't know, some of the factors with COVID-19, but it's a suggested chart. So you have here an incubation period where someone's exposed, And then usually the first response is a fever. And so, and we know that. And matter of fact, that's why, you know, often in the screening, you're going to see before you get on an airplane, they'll take your temperature. And so the first response from your body is a fever. And then again, looking at this chart, there's a graph. So you got IgM antibodies. That's your body's defense, that it's trying to fight the virus. And so your IgM antibodies go up, and as it's having success in fighting the virus, as you're having more success in fighting the virus and the virus is going away, your fever goes away, and the IgM antibodies decline, but then the IgG antibodies take over. And so the IgG antibodies are what is protective. And so that's what helps you from getting reinfected. And so again, this could be a controversial chart because nobody knows how long the antibodies protect. That's something that we're all going to, you know, have to discover. Will it last a year? Will it last 2 years? Will it last 10 years? And so we don't know that. And so this is just, you know, a suggested chart. And so the last, before I change from the chart, but is I put a red bar in here. And so that red bar would be when you could possibly be infectious. And so then this is going to be important, Dr. BRIX, in deciding which antibody or which PCR test that you're going to give, because this is when you're shedding the virus. And so that's, you're shedding actually the most at the beginning, but it's before your IgM antibodies are able to fight and keep the virus down. So you have a lot of, it's a respiratory disease, and so, or respiratory infection, and so you're shedding, and as the antibodies reduce the number of the virus, then you're going to shed less. So COVID-19 testing. So there's PCR or gene molecular testing, antibody testing. And so as we showed in the graph, there are some actual antibody tests that are only testing for the IgG antibodies, but a lot of quality tests are testing for the IgM and the IgG antibodies. And then there's antigen testing, at least the point of care antigen testing that we're talking about here. They're still trying to develop that test. Currently, it has 80% false negatives, so it's not available commercially, but a lot of people are very hopeful with this test, and we can talk about it in a minute. But, you know, Dr. BRIX did say that really, as with 300 million Americans, it's going to be very hard to test for the coronavirus every single American. So we're going to go through the different tests. And so PCR. And so you've seen this, you know, on TV, you know, especially if they're doing a drive-up test that, you know, a healthcare provider, you know, reaches in the window, they do a swab test. And so what the swab test does is it's a respiratory test. And so you're looking for the virus either in the back of the sinus or in the back of the throat. And so what has to be done is you take the swab, you insert it in one nostril, it goes all the way to the back of your sinus, you rotate it for 15 seconds, then you remove it from that sinus, and then you put it in the other sinus, and you take it all the way to the back, and you rotate it. Some people cry when that happens. I wouldn't imagine. It's very fun. And so the problem with it is that it's looking for the active virus. And so if it's before the virus, or if after your body has developed you know, the IgM antibodies and it's fought the virus, there might not be enough virus present. And so that's why they're very specific, you know, guidelines. You know, they'll let you come in for the PCR test, but it's an expensive test. It takes a lot of time. And if you test and it's not within the right window, then it's not going to find enough of the virus to give you a result. And so that's why you often hear when someone takes the test, they might need to take it 2 or 3 times before it will actually find the virus. So there's antibody testing. And so what it's measuring is your body's response to the virus. And so each of us is going to develop different amounts of antibodies. Some people are going to have a very strong response, and in a day or two, you'll find the antibodies. Other people will have a milder response, and it might take 7 days or 8 days. So that, what they basically say is between 3 and 7 days to find the response, to your body with the IgM antibodies. It is an easy test to perform because it's a finger prick. And then you put 2 drops of blood on a cassette. This is showing the cassette. And so that you can see the window there. You put 2 drops of blood, and then it shows you the results, either no virus, IgM, or IgG. And so, so we already talked about that it could show with the IgG antibodies that you have some past infection that offers some possible immunity. What I would say about the immunity, because there's a lot of discussion around immunity, and they say, well, what difference does it make if you have immunity? If immunity doesn't work, then I'm not sure what a vaccine will do, because it's basically giving you the antibodies so that you have some protective response to any future exposure to the virus. So the FDA did create an EUA to allow testing. The problem is a lot of, it's an emergency use authorization, what that EUA means. And so it allows companies to submit data, and then from submitting the data, they can then begin selling the test. Well, there's a lot of companies from around the world that started doing that really had no experience or successful tests. And so the market was flooded with a lot of very poor quality tests or non-functional. Matter of fact, the UK paid over $20 million for tests, and the tests were all bad. And so that's really given these antibody tests a bad name. There are bad antibody tests in America as well. And so what I would just say is that if you want to buy an antibody test, you want to make sure that the manufacturer has experience in making or creating the antibody test. And I frankly would say you should buy from a company that's based in the US, the UK, EU, or Korea. And really, I wouldn't go outside of that just because of the requirements that they would have to develop the test. And then the federal government did, HHS, allowed pharmacists authorization to perform the antibody tests. And I already talked about that the antibody tests should test for both IgM and IgG antibodies. And so when you look at this chart, and I don't know if my pointer will show up here, but so if you can see it here, the virus testing for the PCR test will show, well in that, 0 to 7 days. And then the antibody testing shows up better from like day 5, onward. And so both tests have a window. And so you need to stay within that window to get a positive result or an accurate result. And so just, to kind of finish up here a little bit, the antigen testing is a saliva test. And so it would also be used on a cassette. And so you would take saliva, put it in the window, and then within 15 minutes, it also would give a result of an active virus. And so that definitely has an advantage. And so, that would be a very good test. In the case of PCR testing, you have days to get the result processed in a lab. We already mentioned the antibody test is 2 drops of blood, and it's within 15 minutes. And so that's a point of care test as well as the antigen test when that's developed. And then if the task was too big, Dr. BRIX, to make a decision about which of these 3 tests and when you would test them, we just had in the state of Pennsylvania a a small problem, maybe that's actually it's not a small problem at all, very big problem with nursing homes. And Dr. Rachel Levine, who is the head of healthcare for Pennsylvania, she's come up with a strategy that she's going to test all 90,000 patients and workers. But when they asked her, how are you going to do that? Because if you test at a certain time, you might have to retest. And so how do you test 90,000 people? So it's a difficult problem to solve. And so whether you're testing for 300 million Dr. BRIX or you're testing for 90,000, how will you test? And so I hope you've come up with an idea on that, because really it's fun to imagine you're Dr. BRIX, but you are a doctor that's responsible for your practice and your patients and your staff. And so how will you test? How will you evaluate patients that are coming into your office and keep them safe? And so, so there's possible, and this was from the CDC document, that this was a suggested way that you would screen. So really important, pre-screen by phone. So when you talk to the patient, you know, where have they been, have they had a fever, is anybody in their household, those types of questions. I'm sure you're already doing that or developing them. There's a lot of good screening questions that are out there. And then all that come into the office, including staff, assess their temperature. And if they have a fever, or, you know, if anything over 100, then, you know, reappoint them. If and when antibody testing would be available. If they have IgM antibodies, then, and they're positive for that, then probably the best thing is to, you know, to reschedule, because they're in some, you know, phase of infection. We can really hope and pray for antigen testing, because that would be the best testing and easy to do. And then, you know, ask your patients to notify you if within 14 days of being, you know, treated in your office, if they come up with a COVID-19. So the current regulation for testing by dentists, and it does reference it in the CDC guidelines, that if testing becomes available, so you know, so that there's an opening there for that. You know, so right now, all of the FDA approved tests are set as complex. That means that it's only for CLIA labs to perform. They did authorize the pharmacist, so you could send your patients to a pharmacist, but the ADA has been working with HHS, and actually the ADA's actually created ADA code for testing in anticipation of a possible you know, widespread use by dentists. And then 2 states, North Carolina and Virginia, both are working through their legislatures for testing. But it is a practice around the world for dentists to use the testing for screening. And I would highly encourage you to lobby, especially HHS as well as the ADA, to gain testing. So with that, we'll transition over to air quality. And so the CDC guidelines have more to say about air quality. And so, you know, what I would say about, these are just going to be general categories, not specific products. And you're going to be, you know, offered the opportunity to buy products and to set up systems in your practice for air quality. And so I would say, again, just trying to focus on evidence-based. There's a lot of products out there, you know, some of them, you know, are consumer products, and, you know, are they appropriate for a dental practice? And so I would really encourage, show me your data, anyone that's selling you a product, you know, and it would be really good if you had either hospital or university-based testing, because there's a lot of claims out there. And so just, if you're going to make the investment, you know, make sure it's worth the cost. And I'm talking too about the long-term cost, you know, for like filters and bulbs. You know, the great thing is that in the CDC document, and this is, you know, I was very encouraged by it. You know, they use words in paragraphs talking about different procedure, or, you know, devices or, in relation to your HVAC. They use the words like ideally, or minimize, or wherever possible, or you should. And so not a lot of mandates. So I think they're giving you the flexibility to work towards a solution that's going to be safer for you and your patients. And so please read the document. I do think that, pedodontic and orthodontic practices are going to have a little bit of a difficulty because they want 6 foot of distance between chairs. So that's, it's going to be a challenge. So I like to go from, sort of big to small. And so specifically, this is a whole office solution. And so you would have a system that would be in your HVAC. It would be installed there, and it would have a certain number of room turnovers to take the bacteria and viruses, as well as any VOCs out of the practice. Again, the CDC does have some recommendations around that, and working with a manufacturer as well as the HVAC company. The next would be a extraoral suction. So that's a device placed close to the oral cavity when you're working, and so to pull away any aerosols. And so this would be a central based system that has one central motor, and it vents outside. So no, special filters necessary for each operatory. Then another solution that the CDC talked a lot about this. I was surprised, but they were talking about portable units for filtering the air, both in the reception area as well as in the operatory. And they even talk about certain placement within the operatory. So that does seem to be a direction that they think is it's a practical solution. So again, there's a lot of devices out there, and so please do the research to make sure that they're going to address the bacterial levels and virus levels, as well as air cleanliness. But they talked about making sure that it has a HEPA filter. That would be a base minimum, of course. And then this is a portable extraoral suction for pulling the aerosols away, but there are several out there. So these pull the aerosols away. It takes it into the portable unit, and it does filter it there. Some units have UVC lights in there to make sure that the virus or any bacteria wouldn't be sent back out into the room. And then this is my personal favorite. It's a PAPR unit, and so might look a little bit different these days. But if just 3 months ago you walked into your bank with a face mask on, that would look pretty unusual too. And so I think this is a solution that a lot of doctors will be looking at, because it allows you not to have to use a face shield or face mask. So N95s. This particular unit, the filter will last over a year. And the thing that a lot of doctors like is that it's very cool, not like it's temperature cool. And so but this has been used in a lot of other industries, and there are many companies that make these PAPR devices. So this might be an option, especially with some doctors have a beard, some doctors have sensitive skin, and wearing an N95 mask might not be practical to wear all day, every day. And so, and then last is a HVE, HVE, on an articulated arm. So this can be positioned close to the mouth, the oral cavity. The advantage of this system, obviously, is that it uses your existing suction system. So no special system. It usually has some type of an articulated arm that attaches to the back of the chair, so that you can, put the, sometimes they're narrow, sometimes they're, a cup size, but different shapes to pull the aerosols away when you're, have a procedure. And so, the real question, and again, in the CDC guidelines talks about anytime you have aerosols, to do four-handed dentistry, that's going to be very difficult, obviously, and expensive for hygiene. And so, really trying to look to either an extraoral or an HVE articulated arm for hygiene. So, and this is probably the most recent research paper, so you can look it up, but it was a study on extraoral air and aerosols in operatories. And so this is published in peer-reviewed document. There are several out there, but unfortunately for all of us, they're even older. And so this is the most recent one. But, I will end with, the Department of Labor in 2015 and the CDC in 2018 identified dental office air quality as, not healthy. And so, so in a way, we can take this as an opportunity, to improve all of our health and our staff's health. The COVID-19, I think, will pass, especially as we all, get vaccinated. But, poor air quality in a dental office, that won't pass. And so, making an investment, in improving the air quality, will improve your life and your staff. And so, we can kind of look at the bright side of it is that, this could help everyone. And it's a problem that's needed a solution for a while. And so, let's take this not good thing and turn it into a great thing. And so thank you very much for your time, and have a great Memorial Day. Remember the military who sacrificed for our freedom.
Thank you very much, Paul. That was a great presentation. A ton of good information there for everybody listening. We want to go over to Q&As now and take some of these questions, if you wouldn't mind. The first question, someone's asking, do you recommend extraoral suction in the dental office?
Yes. And so the reason is because it's the point of really where all the infection or the aerosol starts. And so, I do think that, either, a central or portable or, the HVE arms, are all good choices, and you should really, look at those. I definitely think so for hygiene. And if you look at that British study that was done in Canada, and there was one that we saw that was sort of an unofficial one that Temple University just did, and 80 to 90, and it's probably closer to 90% of all the aerosol is absorbed or pulled, with your HVE. So if you're doing four-handed dentistry, you're really only looking for 10%. And so, and you might say, well, boy, this is a lot for just 10%, but it's still 10%. And then the other part of it is what do you do about hygiene? And I think, some type of device would be much less expensive than hiring an assistant for hygiene. But, some people actually think that that's a way we should go too. So I don't know, but that's just my advice on that.
Okay, we showed some air purifiers. There's a question here about that, about HEPA air filtration or HEPA air filters. Do you feel that that's sufficient? And the second part of that question is, do you think when they fog the rooms, or if they do fogging, is that going to affect the performance of an air purifier using a HEPA filter?
Yeah, so two things. So first, I think that the HEPA filters are enough, but I do think once you're going to buy the device, do you want it to also have a carbon filter? So the CDC did recommend a HEPA filter. So I think that's what you're going to be looking at a minimum. But I do think if you're going to buy these devices and, have them, look at, how effective they are. And so that's what I was really trying to point back to is compare, especially, hospital studies or university studies, and make sure you get, the best device, because it isn't trying to get the, what is the minimum, but, if it's going to be sitting there and you're going to pay for it, let's get the what's going to give us the best health for our staff and ourselves. And then back to the fogging. I don't know about fogging. I will say this, is there's no mention of fogging in the CDC device in the CDC literature. I would even just study fogging. Everything I've read on fogging, it's great for surfaces, but it's hard surfaces, but I'm not sure what it does on, carpeting and everything. And I think you're dealing with, hard surfaces as it is with your wipes and your sprays. But, I'm not a doctor. It's not my practice. So these are some things that you're going to have to investigate.
Another question about the negative pressure rooms. You mentioned in the beginning about negative pressure rooms. Do you feel that those are going to become mandatory?
Again, it didn't say anything about it in the CDC guidelines. So I was happy to hear that, because like I said, in Canada, they're trying to mandate that. And so it does talk about in the CDC guidelines that you should have the air move from the, it should not recirculate from the operatories up into the reception area or the, the staff office. And so they would like to have the air move in one direction, and that is probably out, but they want you to investigate that. And so my caveat to that is, what is your state going to require? The reason I say that is that, we here in Pennsylvania had, for 3 days, there was a mandate that you couldn't see any patients unless you had a negative pressure room. And so I think that's going to be very difficult. But with all those, guidelines that are in the CDC, it does say investigate, you should, that shouldn't be really a license to like, oh, well, we don't have to do anything. And I know there's no one on this call that thinks that. But, I think, use this time, to really look at, how do we make a safer environment? It's a real opportunity, and, let's use the time. And then, of course, check with your state agencies.
Thanks. Next question's about testing, and it's kind of a two-part. And I want to address the first part. They want to know, will dental offices have access to the antibody test? And I think that's a question we can't answer here. You have to check with your own state agency to determine whether or not the dentist is allowed to answer or take the test or give the test. The second part of the question is, does the test measure both the IgM and IgG? And when you look at the test, is it evident which is which on the test? Yes,
it does. And it is evident which, yes. It has an IgM line and an IgG line, and back to the testing is that the HHS did give permission to the pharmacists to do the testing, and so I still can't figure out why they won't let dentists and other point of care offices do the test. It's a simple finger stick, but that is something that you should really lobby HHS and get the ADA to do the same.
Paul and Jim, this is Chuck. Can I interrupt for just a second? Question for you guys. Assuming that the HHS does change the requirement and allow dentists to do tests, if you were a dentist, what would you do, or what would you recommend to dentists to do? Because we could wake up on Tuesday morning after the holiday and find out the HHS has made the logical decision of encouraging, maybe encouraging dental practices to test. So assuming that dental offices were allowed to do that and the tests were, as you say, relatively easy to use and easy to administer, what would be the testing protocol that you recommend for team members and for patients? Paul?
Great question. And so, so I would say, first off, I think other countries in the world are doing the antibody test. And one of the things that's great about it, and again, I'm going to say something controversial, is when you have the IgG antibodies, you're immune. And so, and there's some countries in the world that are actually thinking about giving a license to anyone who has the IgG antibodies, because they can't get infected and they can't infect anyone else. And so that would be valuable information to know as well. But in any case, if you have the IgM antibodies. If someone comes in, they're at some point still fighting it. And so it is a good indicator. To do the PCR testing, you got to have, that's a lab test. You got to have a machine. And so it's just not practical to do. And then, of course, if we get the antigen test, just spit into the cassette, my gosh, that'll be, and it tells you if you got an active virus, that's really all we care about. We just want to know who has it. That's powerful. But right now, there's no test that really tells you that. And so, but if I was given the ability sorry, can't get this to stop.
It's a problem all of us have, no worries. So if you could wave a magic wand and you could say that dentists were able to test and the test was easy, what is the protocol do you think most dentists should do for them and their team members?
Yeah,
every day, every patient?
Every patient.
Every patient.
Every patient. And so.
And what about team members?
I don't know that I do it every day, but I'd hope first off that they'd have IgG antibodies. And so, testing, yes, you test every patient. And just keep in mind, it's a finger stick. So it's a little bit painful. It's going to be one more reason why patients won't want to come in. So you want to be careful about it. But I would test. Yes, I would test.
Well, you're saying patients may not want to come in. On the other hand, patients may want to see dentists because they want to get tested. I mean,
yep.
if you were to take a poll of most people in the United States today, I think most people, if the test were easy and insurance paid for it, they would say, as long as I can get it done, I would love to know what my antibody. I mean, wouldn't that be an advantage for dentists? Might that not drive patient compliance and patient appointments and everything if it was easy and convenient for dentists to do the test?
No, good point, Chuck. I do think a lot of people, because it's really interesting. I was just listening, and there's a testing center in Colorado, and so they're going to do 5,000 tests, but you have to submit why you want the test, and if you don't have these three things or one of these three things, then you can't come for the test. Well, there's obviously a huge interest for people, to have the test, and they sure don't want to do a PCR test, with a swab in your sinus. So this is pretty easy comparatively.
So one more question, then I know Jim's got other questions, and Kay may be the right one to answer this question, so I'll give her a warning because I see she's on mute. Is there insurance reimbursement for testing? Either medical, I'm fairly certain not dental, of course not yet, but does medical reimburse for a test pretty easily or not? Does anyone know the answer to that question, assuming that you can get a test?
Say that medical is definitely stepping in the picture quite a bit, and I know that Laura Owens will be the one to answer that. I can actually find that out for you, and we'll include that in the Q&A.
That'd be great, because I think everybody on this panel would agree that at some point in the not too distant future, dentists will be allowed to test. The question is then, when that's allowed, I mean, there's no reason why not. Dentists do these kinds of things all the time. So at some point that will come true. So then what should dentists do about it? All right, so Jim, I know you have some other questions.
Yeah, I just want to do one more before we have to close it up. I want to ask a question about the oral suction devices, the extra oral suction devices. There's a question, should the device have UV incorporated in it inside the device for the filtration?
I would say that the portable one should. If it's exhausting it to the outside air, it's not necessary. But I think the UV would be, I will just tell you this so what does UV do? So I'll answer it quickly. So the UV, the air's not in there long enough for the UV to kill that much as it goes through the box. So what the UV is doing is helping with the filters and to kill anything that's in the filter, like might get stuck in the filter and then go through it. And so it does have some beneficial effect. So that, I would think that it would be a desirable feature.
All right, so we wanted to end the Q&A right now. If your question didn't get answered, there's still a lot more questions. We just don't have the time. But those will be published and distributed to all the registrants, all the attendees. at some point after this is over. But right now, I want to turn it back over to Kay so she could do closing statement.
Absolutely. So Leah, you want to pull up actually, you know what? We do have 5 minutes if you want to keep going. Chuck, if you want to come back on, we do have 5 more minutes. So there's so many questions. We could still answer a few more, Chuck, if you'd like to.
No, that'd be fine. Jim, do you have other questions that haven't been answered?
Sure. There's a question here about tests again. It says, how long does it take to get the results of the test? And how is it useful for treating dental patients if it takes too much time?
Great question. So if you're doing a PCR test, and I was talking to an office it's a very large office, CHC, and so they were talking about if they're doing a PCR test, you got to take the test, and then you have to send the results in. So it takes 3 to 5 days, which is worthless because in 3 to 5 days the patient can get reinfected. And so what is that? So in the case of the antibody test, it's a 15-minute test. You do the finger stick, you take 3 drops of blood, or you put it in a pipette, you put two drops of blood, on the cassette, and within 15 minutes, it gives you a readout of the antibodies or no antibodies.
So another question, I guess, about billing and fees. Someone is asking, is insurance going to pay for the additional PPE that's going to be required now?
That's really all over the board. I will tell you, if you look at Delta's doing so many different things in so many different states. This is what I will tell you. And this was on a webinar that I was on yesterday by Roy Shelburne. He said, yes, you should go ahead and use the new code that the ADA put out. You should bill for it. And he also said to slow down your claims, because what's going to happen is immediately when you bill that code, it's going to put your claims on a hold. He recommends that you build that code separately on its own claim. So you would bill your visit and then bill that code on a separate claim and then send that in so that way it won't hold up your money, because they still don't know. I mean, it's all over the board. I think there's 3 that I know are paying for it, and there's some that aren't. And again, the price has gone anywhere from $10 and Roy sits up to $150. So, and then they were asking too, is it per visit? Like, can you go into a hygiene room and then you go to the doctor's room? Is that double billed twice? Because we have to now do new stuff. So we are going to have a special report with that, with Roy Shelburne to give you more, but I would say, please make sure that you bill it using the code that the ADA provided. And the only advice I would say is do it on a separate insurance form.
Right. Paul, question about air purification here. And they're asking, how long does a room need to remain empty after a patient, so in between patients? And if you install air purification systems, does that affect the amount of time you wait between patients?
So, and again, that was something that really made me happy when I read through the CDC guideline. Is they just said, let the room rest after the patient leaves 15 minutes. And then you do your regular cleaning, that you've already really done before this whole COVID-19. And so they did say to make sure that you're using an EPA approved, disinfectant, but they really don't have any other, time between that. They do talk about trying to space the patients out, but again, I'm not sure how practical that is, but they just said limit the number of patients, that are coming into the office. They read through the document. I'm sure I'm not going to do justice with everything, but I was happy to see a 15-minute rest before you clean. And so, probably take you 15 minutes. So I would think, half an hour, but there's really no guideline or mandate how long you need to leave the room rest. So I was happy about that.
Okay, so someone's posted a question here. When I'm reading the CDC guidelines, I'd like to know, is there an ideal positioning for an air purifier in an office, or do you need to put an air purifier in each operatory?
Again, it's, they have some guidance there, but they were talking about the air purifier being in a direction that it does not pull, past the staff. And so I would think somewhere down near the foot of the chair. But again, if you're having a whole office purification, they asked again that it would pull, down away from the healthcare providers is what it says in the document. And so, I think you're going to have to, but I didn't answer the question. I think in terms of, your air purifier, I think you're going to need to do some investigating on that. Can you have just, one in the hallway? I don't know. I'm not sure that'll work, but I don't know if it will. I think you're going to need to work with the company. Sorry, I'm rambling.
So I'm going to let you guys keep answering questions. I'm going to do a really fast ending because we have so many questions. So why don't we'll end up right on the hour. We still have 6 more minutes. We can answer some of these questions. I would love to get as much information out to these people as we can. So let's keep going.
So Paul, question about the antibody test. Do you have any idea what the average cost is?
To the dentist or to the, that's charged to the patient?
I guess
anyway,
both.
I can get both.
They didn't specify.
I can get both. Benco system, we're selling it. I think it's $25 per test, and I have heard in the the $50, 50 something range. So between $50 and $60, to the patient is what I've heard.
So next question is about pre-procedural rinse. What do you know about pre-procedural rinse, and does it reduce aerosol contamination?
Good question. Actually, great question. It's in the CDC guidelines that they highly recommend a pre-procedural rinse, and I mean that's easy to do. And so I think it's of all the things that we have here, that's the cheapest and easiest one to do. And
I'd like to put a plug in for Glow EcoBalance. We had a program with Dr. Levine, the inventor of it, and put it in an autoclavable tray. It's a fabulous product. I use it myself at home, but it has sodium bicarbonate and hydrogen peroxide. It's a fabulous mouth oral disinfectant prior to any dental procedure.
Good. Question about UV, using UV light. Should you be concerned about UV and ozone exposure?
Yeah, so great question again. First off, CDC, they didn't say too much negative about stuff. And so, but they were really cautious about UV. I'd stay way away from UV because the problem with UV is it's only disinfecting what the light is touching. So if it's underneath of a surface or if it's in a rough surface, it won't even necessarily kill within the pleats of a filter. So how would you expect it to, clean under your desk or chair? And they did say that the UV works well in a device where it's capturing the air and moving the air across it, and especially, in a slower amount. So like in your HVAC system or in your, in a device that could be above the operatory. But, I think UVC has its application, but be careful where it's used because, it can cause harm. But that's why, running around with a wand, how do you know you got, every surface, and you got to get it long enough. So I'd be very cautious about UVC.
But Paul, best practice is to get the air out of the operatory, out of the office, external to the building, correct?
If you can. Yes.
If you can, right, if possible. Then you don't have to worry about disinfecting it. You're just getting it out of the building like a suction system would do, right?
Right.
All suctions are vented outside the building, right? We don't have to worry about filtering air in a suction because it is evacuated outside the facility.
And that's especially true with extraoral, suction. Yes.
Correct.
So Paul, question again, I guess this goes back to the CDC guidelines. They want to know if there's anything in there about requiring doors or any requirements for doors on the operatories.
Nope. That's great. They said it's good. They did say that if you have a known COVID patient, that you really should put them in a room with a door. But other than that, they specifically spoke about open operatories, and they know that they're open. What they did say is that it's, they're asking for 6 feet. I would just say this is please read through the CDC guidelines. I'm 65 years old and my memory isn't the best.
Well, and I want to add to what Paul said. The CDC guidelines may not specify them, and I would point out that those are interim guidelines, right? They are clearly marked interim. At Benco, we believe that the future is for closed operatories. We're not betting that the requirement will be to close in currently open operatories, but whether it's the local state or the local requirement state or the federal, we believe that closed operatories are what people should be building and designing going forward. So if you are considering a new facility, make sure you're working with a team, a design team that understands healthcare design, not just nice design.
Yep. And also too, your state might have a different mandate as well.
That's correct. Yeah.
So that, the CDC, as Chuck said, it's an interim, but, but your state could mandate closed operatories or at least one closed operatory.
So let me just take over right now. I want to say thank you to everyone for coming on. And if we have so many questions, so Paul, your team's going to be really busy answering all these questions. But I just want everyone to know that Benco will do the best they can to make sure that every single one of your questions get answered. And maybe we can come back on and do it again, Paul, because it seems like there's a lot of want for this information, and it seems like it's changing constantly. I do also want to let you know that I did email Laura Owens about the medical question, and she said, again, as long as it's diagnosed in your symptom screening, it would be something that medical would cover. So the diagnosis and, writing it down and making sure that you document it means a lot when it comes to billing medical, but that is what she responded. So with that being said, I really want to say thank you, Paul. Thank you, Chuck. This was an amazing webinar, and I know we need to do more of these. We are going to be scaling back a tiny bit. However, we still are going to be doing some amazing webinars. I know Roy Shelburne is going to be coming on. Laura Owens is going to be coming on. So we have a lot of good things coming your way. So keep an eye on your email, and we will definitely keep sending them to you. So with that being said, thank you, everyone, and have an amazing weekend. Enjoy it with your family. Bye-bye.